But I want to talk to you about how we use methylation. Well, first, my name's Ben, and I'm a bioinformatician in Dr. Anna Goldenberg's lab. And we're in the 12th floor genetics and genome biology lab. And I want to talk about our ongoing project of using LFS patients' methylation profiles to predict age of onset in patients with LFS. So I'll go over a little bit about the background, which I don't think I'll need to spend that much time on, but also the data, the methods we use for prediction, the results that we get, and then the conclusions and the plan from here. So quick background, we all know this, the LFS, it's a rare hereditary genetic cancer predisposition syndrome, and it's characterized by, or the underlying cause is of about 80% of LFS is the germline mutation of the TP53 gene. And it's associated with a spectrum of early onset cancers and a earlier onset in general than other cancers that don't come from a patient with LFS. But what does this mean for the patient? So cancer can occur at any age and almost any body organ, almost 100% chance over lifetime, and a staggering 40% chance by the age of 25. So you can see already it's super important that surveillance is accurate when looking after these families with LFS. So the cancer can be caught early and treated, and that will hopefully improve survival outcomes. But they can be typically resistant to conventional chemotherapy and sometimes even accelerated by radiation. So the data that we have here, at the Hospital for Sick Children reflects kind of the general background that I just went over, that there's a ton of, associated with a ton of cancers. The cancer that we have the most of in our cohort is adrenocortical carcinoma. We also have breast cancer and just a variety of other one-off cancers as well. And the age of onset is skewed to earlier ages. So we can see that even in our data that the average age of onset is pretty young. So we have these 554 LFS patients and their family members here at Sick Kids that we have data for. 302 of them are actually LFS patients. The other 252 are just the family members that we also have we've taken some samples from as well. And of those 302 LFS patients, 149 of them we have this PBMC methylation data for. So of these 149, because not all of them have cancer at the point of the sample collection, 103 have a first diagnosis or first age of onset that we can use as a label in our model. So essentially we have this 103 patients that have cancer, and we want to gauge or predict in some way or estimate in some way when they will get, or at least some confidence level of, or probability of getting cancer before a certain age. And then the other 48 LFS family members or LFS patients that don't have cancer, we can use them as controls to backtest the model. But you'll see that later on. So because we're working with these giant methylation profiles, it's really wide data in the sense that there's over 450,000 variables or features. And like I said, only a handful of patients. So our main goal there is then to reduce the dimensions of this data to make it easier for our model to pick up on the signal amongst the noise. But how we want this to look in practice is basically a non-invasive tool to aid in surveillance. So you'd have a patient, you could do a blood draw, put it in our algorithm, give you a probability of onset before a certain age, and then we have a second algorithm that if that probability is high, let's say before the age of 6, then we can use the second algorithm to detect cancer directly from their methylation. So that would be the general pipeline in practice. So what this looks like, what I was just talking about with the dimensionality reduction, we have these 450,000 probes. We use a series of algorithms to extract differentially methylated regions based off of patients that have cancer and patients that don't have cancer, the ones that I showed you earlier. And essentially, we want to remove the cancer signature from the analysis, because in practice, we'll be using this model on patients, obviously, that don't have cancer. So when we build and train our model, we want to make sure that it's not, the results or the predictions aren't being driven entirely by this cancer signature. So we start with this dimensionality reduction, and that brings us down to about 10,000 probes. And then in step two, we split our model up into training and test data, and we fit the model and predict age of onset. And we use a generalized linear model called elastic net, which will also select the probes that are most predictive of age of onset or cancer. So then we can look closer at those probes and see what's going on. Actually, I can do it here. So, yeah, there we go. Yeah, so essentially it's going to look like how I described it before. We have our patients that have a label, a cancer diagnosis for before the age of 6, and we're going to use their beta values that we have, and we're going to predict the probability of onset before that age. So you can see it get a little scrunched up there, but the results that we have, looks like we lost one too, but we can infer it from, or no, I think it just got messed up on the PowerPoint. Huh. Well, anyway, oh, look, it got shifted, yeah. It's weird. So if you just imagine that is shifted to the right, starting at 0.07, and that before age of 6 is lower, must have happened when we transferred the PowerPoint over from Google Slides. But essentially, our model that predicts the probability of onset before the age of 6, it correctly predicts that a patient will be diagnosed before the age of 6 93% of the time. And then it correctly predicts that a patient will not be diagnosed before the age of 6 89% of the time. So the errors that we have, the one highlighted in red would be the false positive, the ones that we predicted to have cancer too early. And this is not an ideal error to make, but it's we'd much rather make that mistake than the false negative rate, which would be the patients that we miss entirely altogether. So patients that we say aren't going to get cancer, but they end up getting cancer. That's essentially the value that we want to minimize. Let's see here. So then, let's say we have a patient who's 4 years old. They come in and they have, according to the first model, a relatively high risk score for getting cancer before the age of 6. Then we could subject them to the second model that would directly classify if they have cancer at that time. So in this model, we can incorporate not only the 103 individuals that already have cancer, but we can use their controls as well for the no label on whether or not a patient has cancer. So we can harness more of our data and now just predict the outcome as a classification, cancer or no cancer. And then that can give us even more certainty on whether or not more surveillance is necessary. So, in conclusion, methylation in blood accurately predicts age of onset in patients with Li-Fraumeni syndrome. Our model finds 95% the true positive rate, and only misses 5% the false negative rate. And let's see, it's a little different. It's got a little messed up. But as we move forward and with more data, we can improve LFS surveillance protocol by triaging patients based on a simple blood test. That's the ultimate goal at the end. And that's it. I think we have the wrong slide.
Lots of hands are going up here. So, David and then Gareth. David.
So, did you see any time-dependent changes in the signature that might have predicted whether or not somebody had a tumor before the imaging picked it up?
Sorry, could you say that again? Sorry, could you repeat that?
Did you see any time-dependent signature in your methylation profile in the blood? So if you're following somebody longitudinally, that is, they're clear, and they get a spike.
Mm-hmm. The question was whether or not we saw some sort of signature in the blood as we take ongoing samples. For most of the patients, they only have one sample. There's a few that we have, samples at 4 different times, and that's actually something we're looking at right now. Is we're looking at how those methylation signals change over time for the same individual. But yeah, so far what I've seen, it's pretty linear, but it does change. It does alter a little bit, yeah.
So technically, how are you controlling for age at blood draw?
Yeah, exactly. Yeah, so that's the big thing. And actually, we must have gotten the wrong presentation because I had slides on that's like the big confounding variable is the age of the patient. Like how do we know we're not just predicting the age, which the model would pick up on, and it's difficult. We've tried a number of methods to like extract an age signature, but that can end up destroying the signal altogether. But we also have these controls that we can, once we've built the model, we can test our model on the controls that don't have cancer. So based on their methylation profiles, what does our model say? And if it predicts that they already have cancer, then we know it's predicting the age because they shouldn't have cancer. And most of the time in our controls, it predicts cancer in the future. There are a few, as we get to later ages, where it's all over the place. But for our purposes, I think we really only are focused on the people under the age of, let's say, 10, given that's the majority of our data.
Yeah.
It is difficult to imagine that what you're actually measuring is brought in by a methylated change that comes from pre-tumor cells or from cancer cells that would be already existing. It rather looks that you are measuring a sort of systemic methylation change, which is associated with the risk of developing cancer. I mean, methylation change in blood cells.
Right.
What is your hypothesis of what kind of mechanism could cause this sort of systemic
That's a good question.
methylation change?
Do you want to take that one? Essentially, this project started, this was the data that we had available from a previous research, and this is all we had for these individuals. And it started as like an exploratory analysis, like let's see if we can find some relationship between the methylation and age of onset, and we did. But the signal is so broad across, it's not like that there's 10 CBG sites that are super predictive. You can basically take any, yeah, exactly. Yeah, you can take any random couple thousand, and it does pretty good.
Immune cells, maybe.
Well, maybe. Yeah, maybe.
Immune cells in the blood.
Yeah. Some of this was generated from the data that Jason had shown that led to the microRNA 34A as a marker. So there's this differential methylation across the genome. So we don't know yet whether there's a specific one. The 6-year age cut is of particular relevance, and we also targeted that going to the surveillance, just as sort of food for thought, is up until the age of 6. Children, generally speaking, need a general anesthetic to have an MRI. Over the age of 6, generally they don't. So if there was a way to use this as a potential marker to predict that they're not going to develop cancer before the age of 6, you could make the argument that they wouldn't require sedation for an MRI, which is not a trivial thing to do. So the interesting thing about the cut at 6, it gives us some pause for thought of clinical relevance.